COPD stands for chronic obstructive pulmonary disease. The key idea is persistent airflow limitation that is not fully reversible. It includes two major components, chronic bronchitis and emphysema. Start with the biggest risk factor, smoking. Other risk factors include biomass fuel exposure, occupational dusts, air pollution, increasing age, and alpha-1 antitrypsin deficiency. Now let's understand the pathophysiology. Long-term exposure to noxious particles, especially cigarette smoke, causes airway inflammation. Neutrophils, macrophages, and CD8 T cells are involved. This inflammation leads to small airway disease, mucus hypersecretion, destruction of alveolar walls, and loss of elastic recoil. The final result is airflow limitation, especially during expiration. That causes air trapping, hyperinflation, and progressive shortness of breath. Now separate the two classic patterns. Chronic bronchitis is defined clinically as a productive cough for at least 3 months in 2 consecutive years. Think mucus gland enlargement, goblet cell hyperplasia, chronic inflammation, and mucus plugging. Emphysema is destruction of alveolar walls with permanent enlargement of air spaces distal to the terminal bronchioles. Think loss of elastic recoil, reduced surface area for gas exchange, and decrease DLCO. Clinical features include chronic cough, sputum production, wheezing, progressive dyspnea on exertion, frequent respiratory infections, fatigue, and weight loss in advanced disease. On exam, you may see barrel chest, prolonged expiration, accessory muscle use, cyanosis, or peripheral edema if cor pulmonale develops. Diagnosis is made with post-bronchodilator spirometry. The key number is FEV1 over FVC less than 0.70. That confirms persistent airflow obstruction. Other tests can help. Chest X-ray may show hyperinflation and flattened diaphragms. DLCO is especially decreased in emphysema. ABG in advanced COPD may show hypoxemia, increased CO2, respiratory acidosis, and increased bicarbonate from renal compensation. Management starts with smoking cessation. This is the most important intervention. Also use pulmonary rehab, vaccines, exercise, and nutrition support. Medications are stepwise. Bronchodilators are the foundation. Use short-acting bronchodilators for quick relief. Use long-acting bronchodilators like LABA or LMA for maintenance. Inhaled corticosteroids may be added for patients with frequent exacerbations or high eosinophils. For COPD exacerbations, think increased dyspnea, increased sputum volume, or increased sputum purulence. Treat with short-acting bronchodilators, systemic steroids, oxygen, and antibiotics when bacterial infection is likely. High-yield oxygen target. Keep oxygen saturation around 88 to 92% in patients at risk for CO2 retention. Now compare asthma and COPD. Asthma usually starts earlier, is episodic, often has eosinophilic inflammation, and is usually reversible. COPD usually occurs after age 40, is progressive, linked to smoking, has neutrophilic inflammation, and is not fully reversible. Complications include respiratory failure, pulmonary hypertension, cor pulmonale, frequent infections, and lung cancer. For the exam, remember this: COPD is diagnosed by spirometry. Smoking cessation is the most effective intervention. Bronchodilators are the foundation of treatment. And in advanced disease, always think about hypoxemia, CO2 retention, and oxygen needs.